Respiratory system. Clinical examination of the respiratory system. First, observation. Respiratory rate. Patient is cachectic, fever, rash, sputum, fetor locally. Oxygen delivery, mask or cannula, nebulizers and inhalers. On hand examination, digital clubbing, tar staining, peripheral cyanosis, signs of occupation, carbon dioxide retention, flap. Radial pulse examination, rate and rhythm, blood pressure, arterial paradox. Jugular venous pulse, elevated or pulsatile. Face, mouth and eyes, pursed lips, central cyanosis, anemia, Horner syndrome. Thorax and inspection. Deformity of chest, pectus excavatum, scars, intercostal indrawing, symmetry of expansion, hyperinflation, paradoxical rib movement, low flat diaphragm. Idiopathic kyphoscoliosis. On palpation from the front, trachea central, cricosternal distance, cardiac apex displays expansion. From behind, cervical lymphadenopathy expansion. Percussion, resonant or dull, stony dull in effusion. Auscultation, breath sounds, normal, bronchial, louder or softer. Added sounds, wheezes, crackles, raps, spoken voice, vocal resonance. Absent in effusion, increased in consolidation. Wide is a whispered voice, whispering pectoralici. Leg edema, salt and water retention, cor pulmonale, venous thrombosis. On sputum examination, sputum may be serous, frothy, pink in pulmonary edema, mucopurulent sputum in bronchial or pneumonic infection, purulent sputum in bronchial or pneumonic infection, blood-stained sputum in cancer, tuberculosis, bronchiectasis, pulmonary embolism. In chronic obstructive pulmonary disease, there is pursed lip breathing, central cyanosis, prolonged expiration, reduced cricosternal distance, use of accessory muscles, hyperinflated barrel chest, intercostal indrawing during inspiration, cardiac apex not palpable, loss of cardiac dullness on percussion, inward movement of lower ribs on inspiration, that is low flat diaphragm. Auscultation shows reduced breath sounds and wheeze. Heart sounds loudest in epigastrium. There is also raised jugular venous pressure, peripheral edema from salt and water retention and or cor pulmonale. On right side of this page shows pulmonary fibrosis. What are the clinical features of pulmonary fibrosis? There will be central cyanosis, tachypnea, small lungs, that is reduced expansion. On auscultation, fine inspiratory crackles at bases, dull percussion at bases due to high diaphragm. There may also be finger clubbing common in idiopathic pulmonary fibrosis, raised JVP and peripheral edema if cor pulmonale. Right middle lobe pneumonia. On inspection, there will be tachypnea, central cyanosis if severe. Palpation shows reduced expansion on right side. Percussion shows dull right mid-zone and axilla. On auscultation, there will be bronchial breath sounds and increased vocal resonance over consolidation and whispering pectoralici. pleural rub if pleurisy present. The X-ray shows obscures right heart border on X-ray. In right upper lobe collapse, inspection reveals decreased volume in right upper zone. Palpation shows trachea deviated to right side, reduced expansion right upper zone. Percussion shows dull right upper zone. Auscultation reveals reduced breath sound with central obstruction. X-ray shows deviated trachea to right, elevated horizontal fissure, reduced volume in right hemithorax, central hilar mass may be seen. In right pneumothorax, in inspection tachypnea, pain, deflation reflex, palpation shows reduced expansion in right side, percussion shows resonant or hyperresonant on right side, auscultation reveals absent breath sounds on right side. Tension pneumothorax also causes deviation of trachea to opposite side, tachycardia and hypotension. Large right pleural effusion. On inspection there will be tachypnea. On palpation reduced expansion on right side, trachea and apex may be moved to left side. On percussion there will be stony dull right mid and in lower zones. On auscultation absent breath sounds and vocal resonance in right space, bronchial breathing or crackles of above effusion.